new in the YouTube channel for study of MRCOG student is so I'm going to be the share what I'm going to be study with the guideline FRCS MRCOG guideline, um, and today my first topic is going to be FSRH guideline, that is 2019 overweight, obesity, and the contraception. So that was make updated about to be the with obesity overweight patient. So first we have a definition, the table I will share with you this. According to the weight of a category and the body mass index. So we have the weight categories and the body mass index, BMI, the kg per m square. So the patient will be underweight is less than 18.5 and the normal weight 18.5 to 2004.9. So overweight is 25 to be 29.9, and if we will consider as a patient will be obese, it will be 30 to 34.9. And the patient I will be going to be considered obese become 35 to 39.9. If the morbidity obese, this will be more than the 40. This is the updated now for the future for 2024 till 24. So here the some references is several the obese, like currently it is estimation that over half of the women in the UK are overweight, and the obese the ranging is from 53% in the Wales up to the 61 women in Scotland. And the level of the obesity are the expecting to be the continue rising in the UK and globally. So it is an estimation that even out of the 10 people in the UK will be the overweighted, that we consider as obese in the 2020. So in the 2018 report published by the Health England state, and that will be the rate of the obesity was going to be increased among the women who have a reproductive age, and increasing with the number of the women who become pregnant. And the obese, that will be the 19% of the women is a reproductive age in England are obese, and the 3.6 are the severely obese. So these the obese women 5.3% will be become pregnant in each year. So if the obesity with the pregnancy, so giving us the more risk. The criteria according to this to be management, how we will going to be manage the patient is become overweighted, and what complication can be come and how we can manage about obese patient with a contraception. So because obesity is going to be affect every factor, every kind of effect of life. So the best contraception for the obese female is the intrauterine contraception. It is a highly effective method of a contraception and available. That is evidence suggested that the effectiveness, it is not affecting by a body weight or the body mass index, like BMI is increased like more than the 35. It is not going to be effect. So best for obese female is the best contraception is advised by IUCD. So overview, I will take a data on fertility and the sexual activity and the contraception use in unintended pregnancy among the women with raised with the BMI. So fertility going to be effect, while the woman with obesity, the may be experience that reducing fecundity and the fertility because of anovulatory, the polycystic ovarian syndrome, and the insulin resistant. So majority of the women obesity may be continue to overweight and regulated the basis and should be there for the view themselves and having a potential to become a pregnant. So sexually active activity and the use of the contraception. This is the main criteria for to be go to management. So despite the woman is misconception, and available evidence show that the weight of the adult woman in the self a report of a response to be very personal question. So there could be the subject misreporting, or however the data for a US indicate and indicating that the adolescents, the girl will obesity, and more likely they have the older partner. So more likely have been the more than the 3 sexual partner. This in the 1 year, unless the less likely and the using of the condoms than the girls who are not obese. So it is the important note that these is the differences were only the same among the Caucasian girls, but not in African American girls and other the large scale analysis report of a similar finding. So overall, adult women with obesity appear to be similar in the higher risk of untreated pregnancies if we will compare women with a normal weight. So the younger women associated between the obesity and the risk, the seeker, we will say the sexual behavior, maybe they have a great risk of untreated pregnancy and their normal BMI with a counterpart. So this is therefore they said to be this is improve the woman with a higher BMI and like to be the women who have been accessing the effective and the safe contraception. So that going to be support a female as a contraception successfully, and they have to be desire. We will discuss about only the progesterone only implant. So this will like the etigestrol ENG implant. This is a highly effective method of a contraception that is available. Evidence suggesting that is effectiveness. It is not affecting by the body weight. So BMI it is not going to be effect. So progesterone only implant is highly effective, and especially the etogestrol implant. And the license duration of ENG implant use of 3 year apply for a woman all category of the weight. So available evidence that suggests say ENG implant is a safe contraception option for a woman who have overweight, women with obesity. So the single rod etogestrol like ENG and implant we will say as the next Planon, another commercial name. This is only the important currently available in the UK. So this is the method referred to be as implant, and will be the important throughout. This is documentation. There is a limiting data rating to be the implant, but use of the women are overweighted and the women with obesity. So implanting can also going to be the effect with obese patient with the overweighted obesity. So more information of implant and effectiveness of the safety and the weight gain and the benefit is a general population we will refer to as the FSRH guideline progesterone only pill. So we can find the more detail from there. So now I will go to the progesterone only injectable. So available evidence suggested that effectiveness of DMP dipomethylsky progesterone injections. This is not affecting by the body weight or the BMI. So from the limiting over evidence available, it is not possible to be the confirm or the we can exclude the causal association between the Depo-Provera usage with obesity. The while the obesity is alone does not restrict the use of DMP, this is the category in the UK make one category. So this can the safely is used by the female with obesity. So DMPA Depo-Provera usage become UK make 3 when obesity is of a one multiple risk factor. Is the patient will suffer to any other risk factor like congested vascular heart disease, smoking, the diabetic patient, and any like hypertensive, the condition is a risk factor is running with her herself with the obesity. So that is going to be you can make category 3. So we we have to be take care when we are going to prescribe only the progesterone injection, the contraception. So here we have to be care about the risk factors. That is more important. Depo-provera progesterone injections are available to be associated with some weight gain, particularly in the women under the age of age 18, and the body mass index is more than 30 kg per m square. So this is the use appropriate with the some weight gain, particularly women the age under the 18. For a woman with the obesity, if the patient is using as an intramuscular DMP injection are the net and injectable. Consider use as a longer length and the needle deltoid. This is administration should be in the administration in the longer length needles and the deltoid muscle to ensure the muscle layer is reached. Consider use of subcutaneous like DMP and combined transdermal patch. We can use it. So here the patch currently available in the UK is Avira, and the EE and Norilegistrol. The page, the data on the page is a contest of obesity are the limited. Okay, so the patient can be used this contraception according to the need. So progesterone only pill like a POP. If the patient is overweighted and the body mass index is high, she can use as a the progesterone only pill available. The evidence that suggested effectiveness, it is not affecting the body mass. The same the value is considered for another contraception. So availability suggesting that a POP is a safe contraception option for a woman with the though are the overweight, women with obesity. So clinical recommendation here we can they said to be double dose POP contraception. It is not recommended because some concept of the if the overweight maybe the POP will not affect. So here we don't have any like a recommendation to be we will go to double dose of a POP. So here the body mass or the obesity will not going to be prescribed any double dose of the POP. So then we have combined hormonal contraception. That is the most effective, suggested that effective of a COC. It is not affecting the body weight, same as others BMI. So limiting evidence suggested that is a possible reduction with the page effective women with the weight more than the 90. So here the limited. The evidence suggested that the effectiveness of the vaginal ring are not affecting by the body weight or the BMI. Even the combined the hormonal contraception usage in the UKMEC2 for use by the woman with the BMI more than 30 to 34 kg m square, and the UKMEC category 3 will go women whose weight BMI more than 35. So this is the category because of the weight is going to be the risk with another risk factor. So we have to be the follow and look according to be the guideline and going to be managed. So women with obesity should be informed that the risk of a thrombosis will be increased with the BMI. And currently, like combined hormonal contraception use associated with the increased risk of the VT. So current combined hormonal contraception usage associated with a small increasing risk of the MI, ischemic stroke. If the female weight is more than 35 m square kg per m square, the risk associated with the use of the combined hormonal contraception, generally the overweight, then the benefit. So we have to be take care about the prescribing. So emergency contraception, if we will see about the key information, we have available evidence that suggested that the effectiveness of copper IUD, it is not affecting even the body weight. A BMI is BMI. So here the 1.5 milligram levogestrel emergency contraception LNG-EC appear to be the less effectiveness in the woman with a BMI less more than 26 kg m square. The weight of the female will be more than 70. So here levogestrel 1.5 when the patient is going to be take levogestrel emergency contraception. So appear the less effective. The woman BMI more than 26 or the 70 kg. So amiprostol acetate emergency contraception may be the less effective in the woman with a BMI more than 30 kg per m square or the weight is more than 85. So here the clinical recommendation for a woman who's informed that the copper IUD is the most effective method, go for as emergency contraception. And the woman should be informed that the BMI is more than 26 kg per m square. So oral EC, particularly for LNG EC, should be prescribed. And consider the woman with the UPA and emergency contraception, this is not suitable of a double dose of 3 milligrams. So we cannot go to the double dose like 3 milligram because they discuss about 1.5 is not is going to be the effect is a body mass when going to be increased. So the LNG EC, if the BMI more than 26 kg or m square, so double dose UPA with EC is not recommended for a woman any the body weight or the BMI. So this is a recommendation. So we cannot go to use as a double dose. So we have to be go as a copper IUCD for choose as a method to the contraception. So availability evidence that suggested the intrauterine contraception is a safe and contraception option for a woman who have average weight or the woman with the obesity. According to the UKMAC definition, we will go to according to categories. So category 1, we will say to be condition for which no restriction for a usage of a method. So she can use any without any restriction of a contraception. Category 2 is a condition that whether the advantageous using is a method generally is overweight, therapeutical, and or the provoking risk. So this is even the safe when you are going to be used as a category 2, but we have to be take care about even the risk factors and the therapeutical effect. We have to be when we are going to be prescribed, we have to be look for risk factors. Also category 3, the condition where therapeutically or provoke the risk, usually overweight, and the advantageous usage, the method and the provision of a method, expertise, the expert clinical judgment or referral to be the specialist contraception provider, since of one method is not usually recommended. So unless more than the more appropriate method are not available or are not acceptable, the condition is going to be category 3. So here the advantages, the outweighted of advantageous usage of the method and the provision of a method are the required expert clinical judgment and the referral. It means we have to be need especially for patient to be the expertise of experience to be prescription will going to be contraception according to be her risk factor and associated with her life. So category 4 is a condition where a person with unacceptable risk method is a use. It means this is the risk factor. We have more concern with the health, so we cannot go to be take as a safety. This is a category 4. So safety of UKMAC 2016 provide the guide to be informed the safety of UK and the various contraception method, women with obesity and the women who have the obesity and the comparing those with a normal BMI are not be increased and the risk of other disease. So health condition and these comorbidity also is a consider when as a providing as a female with a contraception. So VTE relatively comorbidity including especially with the patients suffering already with the VTE, hypertension, dyslipidemia, type 2 diabetes, congested heart disease, heart stroke, and some cancer like endometrial, breast cancer. The primary, the safety, concern with a woman with obesity and that using the contraception with a cardiovascular risk. So the exogenous, like patient is on exogenous estrogen and including the VTE and the acute myocardial infarction and ischemic stroke also is going to be the safety consideration when we are going to be prescribed the contraception. We have to be look for every risk factor. The safety information guideline respect the risk venous arterial thrombosis, including in the guideline, the risk of the VT is going to be the rise. So BMI if increase more than the 30 kg m square and rising further with the BMI more than 35, and the baseline risk will be VTE obese woman is a twofold higher. Here is the twofold is higher with the patient with the when is the weight is going to be the increase by more than the 30 or 35. So VTE risk is a normal weight female, so we have to be take care about when we are prescribing to be contraception. So now we will look on the effectiveness, like a percentage of the women with the expressing unlimited pregnancy with a first year, the use of the typical use and the perfect use modified from the true cell. So here we have a method, typical and the perfect use. So if we will look on the no method, though the female is not in the any method. So typical use is 85 and the perfect use will be the 85, same. So there is a both are the 85s, same will come. Fertility awareness based the method will be the typical a typical use estimation 24 and the perfect use will be the 0.4 to 5%. Female diaphragm will be 12% is the typical use and perfect use will be the 6 is a half will going to be the perfect use the in the female diaphragms. Okay, the male condom though other you going to be used as a male condom, that will be the typical use will be 18 but only the 2% going to be as a perfect use. So perfect use is the percentage is a 2. This is very less is going to be the perfect use. Combined hormonal contraception, we have the typical use is 9 and the perfect use is a 0.3. And the progesterone only pill, we have typical use 9 and the perfect use 0.3. And the progesterone only injectable perfect use is 6, typical use is a 6 and the perfect use is a 0.2. And the copper IUCD, here the typical use is a 0.8 and the perfect use is a 0.6. So this is good to be we will say to be effective copper intrauterine device. Okay, so the levogestrel intrauterine device is a typical use is 0.8 and the copper IUCD 0.8 and the typical use and the perfect use is 0.6 and the levogestrel system is typical use is 0.2 and same the based the levogestrel intrauterine system, this will be perfect use even the 2. So this is a very effective the levogestrel intrauterine system. So here even the progesterone only implant, even the will going to be the typical use 0.05 and the perfect use even the 0.05. Very good the perfect use. Female sterilization same 0.5, typical use and perfect use even 0.5, vasectomy 0.15. So here the perfect use is a 0.1. Okay, this is the according to the UK make FSRH guideline according to the obesity. So we have now the UK medical eligibility criteria for the contraception, though are the going to be UK category based on the body mass index. If the female, we will see the weight going to be the weight is more than 30 or 34. So this is if the patient is taking to be a combined hormonal contraception, CUC, vaginal ring at the page. So you can make a BMI category 2, and you can make category obesity or the multiple risk factor cardiovascular. This is a category 3 you can make. And the history and if the patient, the same patient is going to be go for a surgical procedure, this will be going to category 2. So the patient with a COC, vaginal ring, page, and the body mass index will be 30, more than 30 to 34. So you can make category 2 with the obesity, multiple risk factor. This is the category 3 if the risk of the multiple like cardiovascular or the smoking are with obesity. This will going to be category 3. But if the patient, same patient is going to be the bariatric surgery, this is a category 2. So if the patient is more than 35 and the BMI, this is category 3, and the UCAMA category along will even 3. So here the same will go to be our criteria whether if the patient more weight of more than 35. So only the progesterone only pill if the more than 30 are the 34. This is a UCAMA category 1 only progesterone pill. Okay, if the patient with the other is multiple risk factor, it is going to be category 2, and the same patient is going to be the bariatric surgery. So this is the category 1. If the more than 35, if the patient is more than 35 and going to be take the same is going to be effect. So progesterone only injectable if we will see the more than 30 to more than 35, this will be you can make a BMI is a 1, and with the risk factor is category 3, and the bariatric surgery is a 1. Okay, then we have the injection contraception like a DMPA at the net end. This is a more than 35 is going to be the same categories. There is no changes. And if the copper IUCD, we will see copper IUCD intrauterine device, if the weight is more than 30, its same category is a 1. Okay, if levogesтрol releasing intrauterine in more than 30 to 34, the category 1, and with the risk factor with the levogestrol is going to category 2. It means that this is the safe. So based on the available data, is a possible to estimation of the absolute risk of the VT among the women with the both of these the risk factor and the combined hormonal contraception, obesity. And however, the absolute risk of weight is a health woman of a reproductive age is small, like 2 event per 10,000 per woman. This is the very important percentage, and like 101 is the absolute risk of the VTE, and associated with the combined hormonal contraception will be 5 to 12, from the 5 to 12 event per 10,000 per year. Even this is a very important. Even we will see the absolute risk of the VT the context of the obesity, and additional with combined hormonal usage is still likely to be the less. So VT risk with the pregnancy or the postpartum, the posing as a woman with the obesity. So however, the obesity should be advised the effective method of the contraception, and that are not going to be associated with the increase the risk. So, and this is my last table. This is the table 3, the medical eligibility criteria contraception. You can make 1 recommendation categories. So according to weight, we have to be look, if we will look at this the table. This is the history of a bariatric surgery. If a patient is going to be the surgical procedure and the weight is less than 30, it is same all contraception. There is no change. But if the patient have a weight more than 30 to 34, and with the hair risk is all with the category 1, but only combined hormonal contraception going to be category 2. If the patient has more than 35 weight, so except the combined hormonal contraception, all have a category 1. But here, when the patient is more than 35, if the patient with a combined hormonal contraception, it will be the category 3. Thank you so much. This is my first discussion with you. I hope you will like, and If you will like, please, if you get any benefit, like me and subscribe me. Thank you so much.